Just wait a few moments. I guess we don't have two senior fellows anymore. We just have our soon-to-be senior fellows. Is that right?
I think so.
Okay, I'll make this a brief one. I'm thinking that next week we should start up. I guess next week is a holiday, but the following week, maybe we should just start doing this in person again, like olden times. What do you guys think about that idea? Or do you prefer doing it on the computer?
In some ways, it's nice to have our own screens
To
be able to look closely at the images.
Whatever you like. It doesn't matter to me, honestly. I agree with you, David. I do think that's one advantage for EP is having sort of a smaller screen that's closer to you. So, well, you guys will let me know. I'm happy to do either. So, okay. All right. So, David, this is a 17-year-old patient with a history of cardiomyopathy. And this was actually a nice tracing I saw on Twitter this weekend. So I thought I would post it here. What do you think the diagnosis is, or can you make a diagnosis from this tracing?
So I'm taking a look at our rhythm and our rate here. Let's see here. So it looks like it's about, 75 beats per minute. I'm looking at our P wave morphology here. I see clear P waves upright in 1. In AVF, not seeing as clearly. Let's go to some other leads, go to V1. P waves are upright in V1. P waves can't see them in 2 either.
What do you mean you can't see them in 2? These are the P wave right here.
Oh yeah, they're actually pretty prominent. So I would guess it's a regular sinus rhythm, upright in 1, upright in 2. Let's see what else. I don't know if I would call it if it's wide enough for a delta wave, but there is a little bit of an upslope on that QRS in 1, but the PR interval looks like it's normal by eyeball.
Yeah. No, the PR, you're right. The PR is about 160. So seems unlikely that it's pre-excitation.
Yeah. And then otherwise, looking at the rest of this here. It does look like the voltages are a little bit low. Nothing too crazy. Let's see. It also looks like the terminal component in V1 looks a little bit slurred.
That's interesting. Yes. Yes, I think you're on to something.
So that would be like a left, like maybe some sort of left bundle delay. But the initial component in V6 and V5 are not prolonged really.
Okay. So far, so good. But there's one other, it's a very subtle finding, but it is an important one to make. And that is this little epsilon wave. A little extra T wave here, little blip on the T wave.
Yes.
The other thing that's odd, right, is that the T waves are inverted in most of the precordial leads, right? By 17 years of age, pretty much all of them should be inverted, but should be upright, with the exception possibly of V1. So we have a right axis. We have right atrial enlargement, right? Because the P wave is pretty tall, right? You yourself said pretty big, even bigger than the QRS in some leads. And you talked about how there was sort of slurring of the S wave here and T wave inversion with this little tiny bliplet on the T wave. So this is a sort of a classic pattern for arrhythmogenic right ventricular cardiomyopathy. So you want to look for this little additional blip on the epsilon wave on the T wave. It's a subtle finding, but when you start to see T wave inversions in a lot of the precordial leads with that, if you had said, for example, that this was a hypertroph, I would have given you credit for that. This could also be with the very abnormal T waves that we're seeing in the precordium. Could have been that as well, I guess. But the epsilon wave and the sort of prolonged S wave are sort of more consistent with this diagnosis. It's a tough diagnosis to make on ECG, but I think this is a particularly reasonable example of that. Okay. All right, let's move on. All right, so this is an 8-year-old whose pediatrician heard an irregular heartbeat. So I'm going to ask Dr. Bibia what he thinks is going on here.
Good morning.
I see. Yes.
I think that there is atrial bigeminy. I see a PQRS, and then I see premature atrial contractions, and they are almost every other beat.
Right. That's right. So this is, I don't know if I would call it bigeminy. There are some parts where it's in bigeminy for sure,
Yeah.
like the first two, but then I think you would agree these are 2 sinus beats in a row with an atrial ectopic. And so this person comes into your office, and now you understand why the rhythm sounds irregular to the pediatrician, because in fact it is. How would you work this up? What would you do for this? What would you want to know about the patient?
I would, I guess, get more of the history, how often this happens.
The patient is completely asymptomatic.
Asymptomatic.
Do you think that that's unusual to be asymptomatic, or is it common?
Probably common.
It's actually very common. It's unusual that particularly young children will feel this, but okay, so you have an asymptomatic 8-year-old actually going to summer camp soon.
I guess I'll do a ZO patch or some kind of monitoring for several days.
I agree with that, but why are you doing that? What is that telling you? I completely agree with your plan, though.
Yeah, I'm not sure.
I mean,
it feels like a good decision.
it's a good feeling, I agree, but well, you want to quantitate it, right? I mean, in other words, if you saw an entire 24 hours with this degree of ectopy, would you expect that there would be any problems with ventricular function?
I guess if it's long-standing enough, it can cause some decrease in the function.
Usually the function is affected by the heart rate and by the density or the amount of ectopy that you have. And although there are a lot of premature beats on this tracing, most of them are sinus. In fact, it's probably like, let's just make a number up, 70% sinus, maybe, or 75% sinus, 25% PACs. So with that degree of ectopy, we would not generally expect that there would be dysfunction or dilation of the ventricle. So we would feel better. But we know when you see this, you don't really know, is this the worst it ever is, or does it actually get worse? Does a child, for example, have long runs of ectopic atrial tachycardia that you're not aware of and that the child is not aware of? So the reason you would do it is you would want to have some understanding of the burden of tachycardia that the child is having. Any other testing you might do?
Echo to see if there is any change in the function.
Absolutely. You would do an echo because, you know, I often joke that the echo is the hemoglobin A1C of tachycardia-induced cardiomyopathy. You know, if the echo doesn't show dilation or dysfunction, you can feel reasonably confident that there isn't a massive burden of arrhythmia in the patient. And then some people might even do other testing like thyroid studies. But in this case, the function was normal. The patient was complaining. This patient had been seen previously by us and was now complaining of chest pain, not an irregular heartbeat, which turned out to be costochondritis. But anyway, it's just a nice clear tracing, I thought. All right. So this is a newborn who was evaluated for a heart murmur. So I'm going to ask Dr. Kong what she thinks about this electrocardiogram.
Okay. So starting out with the P wave, it looks like it's a sinus rhythm at a rate, around 120. Our axis is normal for a newborn. Looking at the precordial leads, the first thing that does pop out at me is the QTC. It does look like the QT looks like it's going more than halfway of the RR, but we'll calculate that. Or actually, the boxes are not so clear, so we might not be able to calculate, but I'm suspicious for that. And then the P waves look a little tall in lead 2, but nowhere else. So I don't think I would quite call it right atrial enlargement, but something that I'll keep in mind. The precordial lead progression looks fine.
What do you make of the upright T waves in the right precordial leads?
We are 1 day old, so we're likely transitioning to be down.
That's exactly right. Yeah. So you examine the patient and you think that the murmur sounds benign. Dr. Arnon is with you, and she adamantly refuses to do an echocardiogram. So what are you going to tell the parent of this patient with this ECG and that exam?
I will tell them that I guess in lay terms, that the ventricle, as much as I can in lay terms, I'll try to say in the repolarization.
You can tell us in medical terms.
Okay, great.
We will assume that you'll water it down a bit for the patient.
Thank you. That the repolarization of the ventricle is a little delayed. It can be normal in the newborn period, but I would like to follow it up likely in 2 weeks, 1 to 2 weeks. Does that sound reasonable, Dr. Pass?
Usually I would follow it up in a month, actually.
Okay.
Yeah, I would wait a month. And that's exactly right. And that is the issue with this tracing, was that this baby was seen and the murmur was deemed benign, which it was, but the QT interval is long. And it just happens I was reading EKGs for Howie one day when he was on vacation, and I saw this ECG, and so I had the misfortune of having to call the family and telling them that this was in fact the finding, and I suggest that they come in about a month. And needless to say, they came the following week because they were so nervous about it. And actually, the QT was about 450 on the follow-up tracing. So in even less than a month, less than 2 weeks even, the QT interval improved. So, this comes up every once in a while. I'm not exactly sure why it is that newborns sometimes can have a long QT interval, but do not in fact have long QT syndrome. But I definitely think that this is a phenomenon. The question always comes up also, how do you know if the QT is long enough that you should actually treat it, right? There are times when you are identifying, well, if you have somebody with 2-to-1 heart block because the QT is so long that the ventricle cannot repolarize in time for the second P wave, that seems pretty obviously a bad form of long QT syndrome that is unlikely to resolve in a week or two. Generally, I will ask the family history. Sometimes you'll find out that someone has long QT, then you'd be a little bit more conservative and probably treat this even in a newborn. Sometimes the QT is just longer. You're not in 2-to-1 heart block, but it's very long, maybe 550 or 600. It's unusual to have a QT even in a healthy person that normalizes, that's over 550 in the newborn period. So this was long, more than the average, but not in an insane length. The other thing you want to look at is the morphology of the T waves. If the T waves just look very strange, lots of inversions and weird leads, a very long isoelectric period, that would be more worrisome. These T waves look basically normal with the exception that the QT interval is long. So in this case, I felt comfortable not treating this infant and just conservatively watching it. Now, since the QT came into a normal range, I'm markedly less worried now about this patient, but I did ask them to come back at 6 weeks of age for one final tracing, or alternatively to have one done remotely and then have it sent to me. And it's important to remember that you should never, if you're looking at QT intervals, you should never ask for a faxed EKG. You always need a copy of the EKG because the fax machine could potentially affect the intervals on the tracing. In fact, maybe 10 years ago, we wrote a paper showing that the fax machine can alter the intervals by over 40 milliseconds. So if this patient happens to live in an outer borough, I would generally recommend that they get an EKG, that a copy be made and that the copy be mailed to us. In this particular case, the patients just prefer to come in, have it done here. So, okay. All right. Moving along. All right. So this is an example of ventricular pacing. And patient has been given 12 milligrams of IV adenosine. And I'm going to ask Dr. Pernabonsel for her thoughts on what we're seeing here, what happened here.
Good morning, Dr. Bass.
Hey, Perna.
So basically, with adenosine, we have heart block, and when we are not pacing, there is no conduction. So that's why there is this, and then we restart pacing, basically.
Right. So the person who's pacing, whose name is Josie, is on the call, stops pacing temporarily, and we see this. What is this here?
This is the P wave.
It's a P
that
wave
is not being conducted.
that is not conducting. So we know
Mhm.
that at least at this exact moment, there is adenosine effect, right? On
Mhm.
the AV node antegrade. We surmise, though, from the paced beats on either side. These are RV paced beats.
Sorry, can you repeat that?
Is there anything you can surmise based on the fact that there is 12 milligrams of adenosine circulating around the AV node at this exact moment on the paced beat? So we see here, when we stop pacing transiently, that there is a P wave with no QRS. So that means we know that there's a lot of adenosine effect on the AV node at this exact moment. And we're pacing the V on either side. Is there anything that we can surmise about the ventriculoatrial conduction based on this tracing while adenosine is circulating around the AV node?
That there is VA conduction. We are not blocking VA conduction here.
And what does that mean? I agree with you. We do not block VA conduction. We have E's followed by A's, V's, followed by A's. What does it mean if there is AV block but not VA block?
That you have a concealed pathway.
Right, that there's a concealed pathway. That's very well stated. And the reason how do you know it's not a pre-excitation pathway? So
Because
just so we're all on the same page, by concealed, you mean it only conducts from ventricle to atrium, not from atrium to ventricle. So how do you know that it's concealed? I agree with that statement, but for those in the audience who don't know, how do you know that?
because when we gave adenosine, had it been a pre-excited pathway, we would have still conducted, and we wouldn't have conducted through the AV node.
Right. This P wave would have conducted, right, A to V, if there would have been a very pre-excited QRS following it. That's not there. And the other thing we notice is that the A's in the coronary sinus pairs are all earlier than the tiny little A's that we see in the His. So this suggests that the patient had a left-sided accessory pathway that is concealed and is not pre-excited. So this was another good test of the presence of an adenosine insensitive pathway, as most pathways are, not all, but most. Good job. All right. This is from ekgrhythm.org. What is the probable rhythm diagnosis? I'm going to ask, we ask David Barris once more.
Okay, let's look at some P waves here. And is there an age for the child?
This is a 7-year-old.
Okay, 7-year-old.
Actually, I'm wrong. This is a 14-year-old. I'm sorry.
14-year-old.
14.
So it looks like the rate would be maybe a little fast. I'm trying to make out the big boxes. It looks like this is maybe over, looks like maybe 150 beats per minute. Is that around what we're talking about, or
like 125? But that's fine. Yeah, it's 125 to 150. Okay.
And I see P waves before my QRS in 1, and they are upright. And I am looking in AVF, and it looks like they are down, and they're down in 2 as well. So we're not dealing with sinus rhythm. Would this be a high right atrium rhythm?
High right atrium.
Low right atrium rhythm.
It could be. Is there any other evidence to support that statement?
Let's see. The PR interval is pretty short. It just kind of, they're like right next to each other. The again, I can't make out the small boxes, but
yeah, the PR is about 110, 120, something like that. What do you make of the P waves in 2 and 3? You already commented that they're inverted in F.
So yeah, it's inverted in 2 as well, and in 3, it's also inverted.
Right. So this is coming from the inferior portion of the heart, if this is an EAT, right? So when you have EAT, normally we say that it's associated with first-degree heart block. However, if the focus is very close to the AV node, as it would be in the posterior septal region, it's not uncommon that there might be a shortish PR interval. So that's one possibility. This could be EAT. Is there anything else this could be?
I'm not sure. I'm just thinking about. I mean, I know that we have tachycardia and it's non-sinus, and I'm trying to think like if it was a junctional rhythm, we wouldn't have any P waves before the QRS. So I'm not really thinking about that. And our QRS QRS appears narrow, especially for a 14-year-old. So I'm not thinking about ventricular rhythms either.
What do you think of the R to P?
I mean, and it would be a long RP interval. So I guess, PJRT is an example of a long RP interval.
Right.
So I guess that's on the differential for this patient.
Right. That's exactly right. It is. And it's always sometimes challenging when you have a patient with EAT or PJRT to know which of those two it is from the surface ECG. So the differential of this is some kind of atrial tachycardia, just like you said, in EAT. Another one could be atypical AVNRT with a fast, slow, with a very slow retrograde pathway, which is unusual, right? Usually the antegrade is slow and the retrograde is fast, but you could have fast, slow, where the antegrade is fast, but the retrograde is the slow limb. And we had that just a few weeks ago in the cath lab. And then you can have a PJRT, where again, you're going down the AV node, and then the VA conduction is over a slowly conducting accessory pathway. So that's another possibility. And you would have to, a lot of these would have to be, you could base this, if you watch this rhythm for a while, you might be able to make a distinction between PJRT and AV and EAT, based on whether it stops and starts suddenly, whether it heats up or slows down slowly. These would be clues to whether it was EAT or PJRT. Nice trace. All right. This is an ECG of a patient who had a WPW ablation. Is there a problem here? And if so, would you treat this? So why don't we ask Dr. Bibia what he thinks?
So if we look at the PR interval, it looks like that it's prolonging, and then there's a Wenke block, there's a drop. So based on that, I would say that this is a second degree heart block. Mobitz 1. Mobitz 1.
Yes, thank you. So if this is following ablation of WPW, where is it that you think that the pathway might have been?
I mean, obviously close to the AV node.
Probably so. So is this an acceptable? We've talked about the fact that Wenke block can sometimes be a normal finding. This is a tracing obtained, I think, in the recovery room following an ablation. Would you say this is one of those normal Wenke blocks that we sometimes see in healthy kids? Is it not? What do you think?
Well, I would be concerned. I think it's not. I mean, it's not normal to see it. It's a complication of the ablation.
Right. I mean, it would be normal to see this when somebody is in deep sleep, but
Right.
It's not normal to see it in an awake patient, particularly one who had ablation of a pathway near to the AV node. So this is a
What
very.
am I gonna do?
That?
Sorry. No, I thought you were gonna ask what am I gonna do.
Yeah, this is a very worrisome tracing, very disappointing and scary. What would you do about this?
Remind me, please, how many?
Have diarrhea or vomit. What are you gonna do about
Like
it?
Ivana. All right. So how many days since the ablation?
This is 3 hours after the ablation.
3 hours. Yeah, I guess doesn't pretty much. And I'll start steroids.
Right. Sounds like you phoned a friend there, but yes, you want to. Typically, we would give steroids in the hope that this is what we sometimes refer to as lesion creep, which is a suggestion that there's maybe inflammation around the edges of a burn that over time encroaches on the AV node His-Purkinje system. And the hope is that if you give high doses of anti-inflammatories, that it will reduce that and the node will recover. So that's really the only thing we would do. If the heart rate was too slow, where would you observe this patient? Would you send them home with steroids? and say, come back in a week? Well, how would you manage this?
No, I would admit and monitor inpatient.
Absolutely. This patient should be admitted to a telemetry floor or an ICU. It should be monitored. And, then the question comes up whether or not they should have a temporary pacemaker wire, which would typically be placed through the IJ for comfort of the patient. But depends really on what the heart rate is and, what the rhythm looks like over time in the recovery room, I think. It's a little bit of a worrisome finding. All right, this is a patient who has hypertrophic cardiomyopathy with a history of palpitations. So a event monitor was placed on this patient. And this is the tracing that was obtained. I'll just show you the rest of it. So it goes into this faster heart rhythm and then seems to go back to normal rhythm. So let me ask Perna, what do you think you would do about this, if anything? Patient was asymptomatic. Actually, no, patient felt this. Patient did feel this.
But I assume was hemodynamically stable.
Well, patient didn't faint.
Okay, yeah, that's what I meant to ask. Okay, so here first we see narrow QRS complexes and then we see wide QRS complexes in this tachycardic rhythm, which self-resolves and goes back to baseline. Narrow complex which looks like sinus. So I would call it non-sustained VTAC in a patient with hypertrophic cardiomyopathy.
Okay, I agree with that diagnosis. So what would you do about this? So you're tracing back, you're like, oh, she really is feeling something.
I would do a stress test on this patient.
How would a stress test help you?
If there is a non-sustained VTAC in a patient with hypertrophic cardiomyopathy, I think that itself qualifies for ICD placement.
That's right. There's really little indication for a stress test, at least at the time in these patients. So let's just briefly go over what the indications or the risk factors that have been identified for sudden cardiac death with hypertrophic cardiomyopathy. So these would all be things that would make us strongly consider implantation of a defibrillator. So the first is a prior sudden cardiac death event due to VT or VF. This obviously is pretty self-evident. If you've died and been resuscitated, you probably deserve an ICD. Patient has unexplained syncope. That would be something that would be a marker for sudden death. We've talked about if the LV thickness is greater than 30 millimeters, and that's anywhere in the heart. It's a common mistake that people think it's only in the septum. The septum is often the thickest part, but it could be anywhere in the heart, in the LV. If there's a thickness greater than 30 millimeters, there is a much higher incidence of sudden death. Non-sustained VT is a marker for increased risk of sudden death. An abnormal blood pressure response to exercise, by that what they mean mostly is an inadequate increase in the blood pressure while exercising. As you know, there's a normal and an abnormal response to blood pressure to exercise. If you don't increase your blood pressure, here it says defined as a decrease in systolic pressure of 20 millimeters of mercury or a failure to increase systolic blood pressure by 20 millimeters of mercury while exercising. I think the latter is the more common that's seen. This is of all of these, I think this one has the least statistical power. It is statistically significant, but it's the lowest. And I don't think most people would put an ICD in someone exclusively for that finding. But usually people who have that finding in the setting of hypertrophic cardiomyopathy have something else, have one of these other factors. And then, so that would be a reason to do a stress test, I guess. And then if there's a family history of sudden cardiac death, particularly someone who was very close in the family, although once I remember discussing this with Barry Marin, and he just said, well, if you have the gene, you have the gene, and it doesn't matter how close of a family member it is. I don't know that I would be quite as adamant as he was in that regard, but definitely if your father or mother have died suddenly from hypertrophic cardiomyopathy and you have hypertrophic cardiomyopathy, I think some would say that that would be an adequate rationale to place an ICD. So in this patient, as you properly said, Perna, if somebody has non-sustained VT on a Holter and is symptomatic from it, then that would probably warrant implantation of an ICD. So what do you think about putting the person on a beta blocker instead?
That would not prevent our VTAC.
That's right. There's no evidence that that is in and of itself adequate. I used to work with a very wise cardiologist, Alan Hordoff, who's now retired. And Alan, used to say that he thought it did help reduce risk. It just didn't help to a degree that it didn't help to a degree that probably was measurable, but it was probably not zero either. So he felt that patients like this should also be on a beta blocker. There are other reasons that we would put people on beta blockers, such as reduction in LV outflow gradients and things like that. But in terms of prevention of sudden death, there really is not much evidence that it reduces the risk for sudden death in this particular situation. So, and I think with that, I'm going to be a little short today, but thanks very much. And I guess we're off next week because of it's July 4th holiday is being celebrated on Monday. So we'll be back. I think actually the following week after we're going to do, I believe Perna has me scheduled to do the basic review of EP. I think if not, then we'll do a regular one followed by that. But at some point in the next 2 weeks, I'm going to do the sort of overview of electrophysiology. It's predominantly geared for the first year fellows. Obviously, anybody who'd like to come and listen is invited. So, all right, everybody, have a great day. Thank you very much.
Thank you, Dr. Pass.
Thank
Thank
you.
you, Dr. Pass.